Today, we're talking all about IVF medication protocols. Understanding the IVF medication protocols could be life-changing for your treatment. In the beginning, when IVF was first performed, it really was based on a single egg at the time of ovulation. And now we're all about getting as many eggs as we can based on your egg reserve. There's one big problem, one big risk that we face: premature ovulation. The hormones involved with the menstrual cycle in a nutshell. It's really important to understand all that because that is how we hijack the system. I do want to quickly mention something about mini IVF. If you are minimally stimulating someone who has a good ovarian reserve, you are increasing the likelihood that they may need to do this multiple times, which, sounds like a really good incentive to make more money. If this show has helped you, the best thing you can do is subscribe, rate, and review, and even share it with a friend. So many women deserve to have this information, but just haven't found it yet. So help me get it to them. Welcome to Trying, a podcast about women's health, hormones, and fertility. All right, guys, welcome back to another episode of Trying with Dr. Sasha Hakman. Today, we're talking all about IVF medication protocols. So this is going to be a really sciencey, really detailed episode because there is so much lack of understanding when it comes to IVF medications, the emphasis that is placed on the protocols. And I think if you have a better understanding of why we do certain things that we do, understanding the nuance behind it, who is a good candidate for what kind of protocol, how the medications even work, um, it allows you to sort of have that discussion with your doctor a lot better to potentially bring up things that may or may not work for you from something you learned from a physician and not from a friend. Because my biggest pet peeve as a doctor is when a patient says, "My friend tried XYZ. Can we do the same thing?" But you are not your friend. I don't know anything about your friend or their medical history. And so this is where understanding the IVF medication protocols could be life-changing for your treatment. Okay, before we get into the actual medications, I want to start off by explaining the menstrual cycle once again in detail because unless you understand something called the hypothalamic-pituitary-ovarian axis, yes, that's a mouthful, HPO axis, you can't fully understand how these medications work and why these protocols exist. So I'm going to go over the HPO axis, explain the menstrual cycle. I'm then going to discuss the different medications that are on the market and their mechanism of action, and then piece it all together with the different types of protocols, the patients who benefit most from what types of protocols, as well as protocol add-ons such as specific priming medications. And we'll talk about what priming is. Okay. So let's start with the menstrual cycle. The thing that so many people think they may even understand, especially if you're going through trying to conceive and you're tracking your ovulation, that is fantastic. But even the majority of women who track ovulation don't actually know how the menstrual cycle even functions. So let's get into it. There is something called the hypothalamic-pituitary-ovarian axis. The menstrual cycle essentially involves communication between the brain, the ovary, and the uterus. But the HPO axis is specifically with the brain and the ovaries. The ovaries then will influence through hormone production what the uterus does in preparation for a hopeful pregnancy. And we're going to talk as if you're trying to get pregnant because if you are watching this episode, chances are that you are either freezing embryos for the future because you want to get pregnant one day, or you are actively trying to get pregnant. So, with the HPO axis, hypothalamus, what is that? That's the control center of the brain. It's located roughly in the middle of the brain, and it is what is keeping your homeostasis. Everything from all of your hormones, your blood sugar levels, your electrolyte balance, your body temperature, how you respond to everything in your environment, the hypothalamus is what controls it. It is like the CEO of your body. Then connected to the hypothalamus, right underneath it, is something called the pituitary, and the pituitary is connected to the hypothalamus through a stalk. So if you look at the cartoon images of a pituitary, it looks like testes because there's an anterior pituitary and a posterior pituitary. We're going to focus on the anterior pituitary because that is the one that's responsible for reproduction. And it is also responsible for hormone production of other systems like your thyroid and your adrenal, and obviously your ovaries, which is part of your reproduction. So the hypothalamus produces a hormone. The way it controls your reproductive cycles and your menstrual cycles is through a hormone called gonadotropin-releasing hormone, or GnRH. Anytime you see the words releasing hormone, it means that it's a hormone that's responsible for the release of a different hormone downstream somewhere in a different organ or a different part of the same organ. In this case, it's a different part of the same organ, which is the brain. So, what is gonadotropin? Gonadotropin is the medical term for FSH and LH. Those are the two hormones the pituitary secretes that tells the ovary what to do. And it describes exactly what its action is. Everything is named on purpose. So, how is it possible that one releasing hormone, which is GnRH from the hypothalamus, can dictate the release of two different types of hormones? How does the pituitary know which one to release? The way that it knows that is through the amplitude and the frequency of that hormone release. Most hormones are released in a pulsatile manner, meaning if I check your cortisol now or I check your cortisol an hour from now, they're going to be different, and that's normal. This is why random cortisol tests are not helpful for the most part. And so when you have GnRH that has a specific amount that's being secreted in a specific frequency, it will favor either FSH, follicle-stimulating hormone, or LH, luteinizing hormone. Okay? Now, FSH, follicle-stimulating hormone, is the hormone, and if you haven't seen my IVF 101 episode, you should really, really watch it. This will be a review of that. But with FSH, it's a hormone that's responsible for growing your follicles in your ovaries. The follicles act as containers for your eggs. Most of your follicles are in the resting stage. We cannot dictate how many follicles you have. The body decides that. As fertility doctors, we work with what the body gives us. Some women have a lot of follicles that rise to the surface of the ovary throughout the menstrual cycle, and others have very few. This is how you have someone with high ovarian reserve and someone with low ovarian reserve. And that's why ovarian reserve markers like your AMH level or your follicle count on ultrasound will dictate your medication dosing and protocol. But FSH in a natural menstrual cycle is responsible for the growth of one follicle. Okay, so let's say, for example, between both ovaries, you have 10 follicles, just for an easy number. They're going to compete with one another when FSH gets secreted, and only one is going to dominate and grow, and the rest are going to undergo programmed cell death, which in the ovary is called atresia. And this is normal, it's physiologic. Okay, now when you start your first day of your period, your body knows that you're not pregnant. And so that is what the brain wants to do. It wants to get you pregnant to propagate our species, just like other animals. So GnRH, it manipulates its pulsatility to then tell the pituitary to release FSH. FSH will then tell the ovary to grow a follicle. And these follicles are going to compete. And a good analogy I can think of right now off the top of my head is like, imagine putting a popcorn bag in the microwave and you hear that first pop, and then you remove it from the microwave. So that's the one follicle that takes over, and the rest are like basically garbage. So that's what happens. FSH is released, one follicle grows, but how come the rest of the follicles don't grow? What's happening here? The one follicle that dominates and grows, within that follicle, you have fluid, which is called follicular fluid, that nourishes the egg. The egg is surrounded by a crown of cells called a cumulus oophrus complex, or COC. And part of that cumulus oophrus complex is some of the cells making estrogen. Those are also the same cells making your AMH, and that's how we can detect ovarian activity and ovarian reserve. So those cells are making estrogen. As estrogen rises, it sends feedback to the brain. So they're all communicating, right? Tells the brain, hey, I got this, I'm growing. So the brain stops releasing FSH in order to have one egg released at a time because the body's goal is generally to have one baby at a time. This is why, obviously things like twins and triplets can happen, but that is not the norm, obviously. So as soon as it sees that there's one egg ready, because of rising estrogen, FSH drops down, stops being secreted. Once estrogen plateaus or reaches a certain threshold, the brain somehow senses and knows that the egg is ready. So this is where you get the LH surge. And that LH surge is responsible for two things. One, to mature your egg, and then the second, to rupture the follicle and release the egg. The follicle that releases the egg will then reseal and become something called the corpus luteum. This is why this is known as the luteal phase. This is the part of the menstrual cycle that is now preparing for possible pregnancy if you had sex and if the egg got fertilized, assuming that everything is functioning correctly, which if you're doing IVF, in most cases, it's because there's something going on. As many of you know by now, I manage a hormonal condition myself, which I historically thought was PMOS, and I really wanted to control my condition through diet. As a result, I've always been the one who stands in the aisle of the grocery store reading every label. And now that I'm a mother, I'm trying to optimize my kids' nutrition. And I often have to tell my kids no to half the snacks they see and want. And it honestly gets old. I previously got my first Thrive membership in fellowship training, and it has never disappointed. Some of my favorite items I buy on repeat, including the Simple Mills almond flour crackers, almond butter, and most of all, brahmi pasta, which is the best protein pasta on the market, in my opinion. What's crazy is I used to think that Whole Foods was the gold standard for grocery shopping, but they only limit 300 harmful ingredients. Meanwhile, Thrive Market limits over 1,000. They pre-read the labels for you, making your job so much easier. So when I'm short on time and I need to order snacks for my kids, I love using the filters, including dye-free, high-protein, sugar-free, to make shopping quick and easy. It's $5 a month, which is such a small fee for a store that already did the label reading for you. Plus, it gets shipped straight to your home, so that's one less errand for you to run. Check out my link at thrivemarket.com/trying for $20 off your first 3 orders, which basically covers the membership. Grab it before the offer ends. Again, that's thrivemarket.com/trying. A question I get a lot from patients trying to conceive is what they should be doing about their tap water. And it's a reasonable thing to wonder because, as we all know, research has linked certain endocrine disrupting chemicals, things like PFAs and chlorine byproducts, to hormone disruption. And a standard fridge or pitcher isn't always built to catch a lot of these things. And that's what led me to look into AquaTrue. It's a countertop reverse osmosis purifier that's third-party certified to remove 84 contaminants, including lead, chlorine, PFAs, and microplastics, that doesn't require any plumbing or installation. It just sits on your counter. And at the end of the day, reverse osmosis is genuinely one of the more rigorous filtration methods that's out there. So if you're already thinking about ways to lower your everyday exposures to endocrine disruptors, this is a reasonable place to start. Head to aquatrue.com and use code Dr. Sasha for 20% off your purifier. That's aquatrue.com, AQUATRU.com, code Dr. Sasha, and it also comes with a 30-day money-back guarantee, so there's no real risk in trying it. Once you are in the luteal phase, that corpus luteum is now responsible for producing progesterone and to some extent estrogen as well, but mostly progesterone in order to make the uterine lining sticky. So in the menstrual cycle, you have the follicular phase, which is the first half. It's all about growing the follicle to release the egg due to FSH, follicle-stimulating hormone. Then you have the LH surge, which prompts ovulation to enter the luteal phase. Now, what's happening with the uterus in this stage? Okay. Simultaneously with the uterine lining, you have what's called the proliferative phase, and then you have the secretory phase. The proliferative phase is concurrent with the follicular phase. This is where, as your estrogen rises, it causes the uterine lining to thicken. And then after you ovulate, once progesterone rises and it gets secreted, that then causes the uterine lining to stop thickening. So your lining actually might get a little bit thinner after you ovulate. That's called compaction. That's normal. And it becomes sticky so that if an embryo were to enter the uterine cavity, it more easily sticks to the lining, can invade, and now take over the blood supply for a pregnancy to occur. So that is the hormones involved with the menstrual cycle in a nutshell. And it's really important to understand all that because that is how we hijack the system to do it more efficiently. Because if you were to do IVF naturally and you get one egg at a time, you're going through an egg retrieval, you're paying for the cost of fertilization and embryo development for a very, very, very small chance in comparison to being really efficient and getting all of the eggs of that cohort in order to maximize the chances of the one IVF cycle being more successful. You need a lot more contenders to maximize that chance. Not saying natural IVF is not possible, it's just really not optimal, and it's definitely not efficient and not cost effective. So the goal behind IVF originally, as things evolved over time, because in the beginning when IVF was first performed, 45-ish years ago, it really was based on a single egg at the time of ovulation that it would occur. And now we're all about getting as many eggs as we can based on your egg reserve. So let's go over the medications and their mechanism of action. So if we start with the basics, when we are doing ovarian stimulation, so this applies to whether you're doing egg freezing or IVF, we are trying to grow the available follicles to a certain extent. If you have really high egg reserve, we don't want them all because that's also risky. You can develop something called ovarian hyperstimulation syndrome. So when we are stimulating the ovaries, generally we are trying to grow as many follicles as we can safely. How do we do that? We already know FSH grows one follicle, but the brain doesn't secrete enough to grow a lot of follicles. So we are now taking over and supplementing the FSH through an injection form. The reason these are not oral pills is because they actually get digested very quickly and they're out of your system in no time. It doesn't work. So unfortunately, the route of administration that works is subcutaneous. That is the most common form. Technically, there are some intranasal medication formulations, very rarely used. It's not a common thing that is done. So generally worldwide, it is subcutaneous through subcutaneous injections, hence why we call them IVF injections. The FSH is the main hormone we are using here, and there's two main ways that we give it. One is a recombinant FSH, meaning it's lab made, and it's highly effective, and it is very commonly used. The second is called human menopausal gonadotropin, and that's because it's extracted from the urine of menopausal women, HMG. The trade name for this in the US is Menopur, as well as in Canada. I really cannot speak on all the European meds because I don't prescribe them and I don't use them. I do review a lot of European medical records for patients that come to see me from abroad, but usually I just ask for the generic name to understand which formulation it is. Globally speaking, almost always you will get, except for a few exceptions, you will get a combination of the two, the recombinant FSH and the human menopausal gonadotropin. And most commonly, you will get more recombinant FSH than the HMG. Now, the biggest difference between the two is that the recombinant FSH is only FSH. The HMG does have LH in it because it's extracted from the urine of menopausal women who secrete both a lot of FSH and LH. So you're going to get both in the urine. They work synergistically together to get a really great response. Now, the dosing of these two medications does vary by practice, by doctor. There's a lot of preferences there. Generally speaking, a lot of the studies show that having a 2-to-1 or 3-to-1 ratio of FSH to Menopur, FSH being either Follistim or Gonal-F in the US, is optimal. And this is the strategy that the large majority of centers will implement. So what makes an IVF protocol different? Now, when you are doing ovarian stimulation and you're getting these two medications, you are now recruiting the available cohort or group of follicles that are there from the beginning of the menstrual cycle, or maybe even before the menstrual cycle. And we will talk about that later. So let's say you're starting with your menstrual cycle, you have 20 follicles. We want to grow all 20. You are getting a specific dose of FSH and HMG to grow these follicles. But now your estrogen is rising so much more rapidly that there's one big problem, one big risk that we face: premature ovulation. There's nothing more devastating than being mentally prepared for an egg retrieval, feeling so hopeful going into an IVF cycle, spending so much money on these medications, and then when you go in before your retrieval, finding out that you ovulated all of these eggs. If you ovulate them, they're now gone. We can't get them. We can't do anything with them. So we need a strategy to prevent that premature ovulation. The form of prevention is usually what dictates the name of that particular protocol. So let's start with protocol number 1, which is the most commonly used protocol worldwide. There are doctors who only use this protocol. It's definitely not the only protocol I use personally, but there is a big reason for that. So let me first get into the trigger medications before we go into the ways to prevent premature ovulation, because this will make more sense once I do that. If you recall, in the menstrual cycle, I did explain that after as your LH surges, it is responsible for maturing your egg, meaning you have 2 copies of your chromosomes, it splits it in half, resumes meiosis, so that now the egg can accept DNA from sperm in order to get appropriately or normally fertilized. So it's not just responsible for ovulation, it's responsible for maturing the egg. So once you have taken your IVF meds, so your gonadotropins, we now understand these terms, so I'm going to use them. If you're taking gonadotropins for an average of 10 to 14 days, however long your stimulation process is, your follicles are now ready on ultrasound. They are measuring anywhere from 15 millimeters to 25 millimeters in size. Yes, it's a big range, but that whole range can provide really good quality eggs. There are 2 ways to mature your eggs. You have to take something called a trigger shot. The trigger shot is mimicking the LH surge. Why? Because we want to mature the eggs. Immature eggs cannot be fertilized in the lab. There is no technique to do that. There is a technique to do that, but it's still considered experimental, and the pregnancy rates are nowhere near as high. So until then, we still trigger. And the 2 ways to trigger, number 1 is called a GnRH agonist, aka Lupron. So as you recall, we talked about GnRH from the hypothalamus, which dictates the release of FSH and LH. So a GnRH agonist means that it promotes the endogenous release of FSH and LH from the brain. So when you take that as a trigger shot, you are naturally producing an LH surge to resume meiosis, and it is perfectly timed with the egg retrieval, approximately 36 hours apart, in order to get that maturation. Immature eggs, unfortunately, do tend to stick to the wall of the follicle, and when we do an egg retrieval, we're just going in to suck the fluid out. We can't see the eggs, they're microscopic. And so usually we hope that they're floating somewhere in the middle of the follicle. And if they're mature, they usually are. But if they're immature, they could be stuck to the wall and we never get an egg out of that follicle. So this is why the trigger shot is so important. It's not only for the fertilization of the egg, it's for actually retrieving it during the egg retrieval. Now, there's a second very important type of trigger shot, which is HCG. And HCG, which is also known as the pregnancy hormone, is biochemically the same as LH. It just lasts longer in the body. An HCG trigger is very powerful. It's very potent. It's very good. But it's not inconsequential if you have high egg reserve. Okay, and I'll explain why in a minute. So those are the 2 trigger shots. HCG in some studies have been shown to give you more mature eggs compared to Lupron, but it is very nuanced There are two ways to do the Lupron trigger. You can either give it with HCG, and that's called a co-trigger, or you can give Lupron twice, which is called a double Lupron trigger, where you get it 36 hours before the retrieval, and 12 hours later you take Lupron again, because in a subset of patients, the Lupron trigger will not work the first time, and you need that second one to really help it. The other thing is Lupron really does not last long in the body, and so many of us will give the double Lupron trigger to ensure that there's adequate amounts so you get full maturation of the cohort of follicles that you have stimulated and worked so hard to get. So those are your main medications to stimulate the follicles and then trigger the eggs. You have your gonadotropins as a summary. FSH, which is recombinant, HMG, which is the one that's extracted from urine of menopausal women. And then you have the trigger shots, which is Lupron, or what's called a GnRH agonist. And then you have your HCG, which is biochemically the same as LH. So now, protocol number 1, the most common one, the antagonist protocol. This is where you are getting either Gonal-F or Follistim. They're interchangeable. They're the same with Menopur, either at a 2-to-1 or 3-to-1 ratio typically. And then as you're going in for your ultrasound monitoring to watch the stimulation and how you're growing and responding, at some point you have to add the antagonist. So remember, I talked about Lupron being a GnRH agonist, which an agonist is what allows the release of a particular hormone. A GnRH antagonist blocks the receptor, so it blocks the function. So by giving a GnRH antagonist, you are blocking the brain's ability to release LH so that you do not prematurely ovulate. Everyone's protocol of when to start this in a stimulation is a little bit variable. And there isn't one superior way based on the studies. There is just personal experience, physician preference, as well as in larger IVF centers, there's standardized protocols. So, with that being said, when you the main times that you would start the antagonist is either when the largest follicle is somewhere around 12 to 15 millimeters, depending on the physician's protocol. It could be when the LH starts to rise, usually above 10, or it could be when progesterone starts hovering, creeping towards 1 or surpasses 1, then the doctor will start the antagonist. Another standardized protocol that some will do is just starting on stimulation day 6 for everybody. The reason I personally don't love to do that is because sometimes it can sort of halt the growth and slow it down, and then you end up having a longer stimulation or a little bit of a blunted response, which we don't like that. We don't want that. So that is your antagonist protocol in a nutshell. The main reason this has become the number one preferred protocol globally is because it's the safest. It is truly so successful and so safe. And the main reason it's safe is because if somebody hyper responds to their medications, then you can give a Lupron only trigger. Why would you want to do that and not give HCG? Especially given that I said sometimes HCG will give you more mature eggs. Well, because HCG is the main culprit for ovarian hyperstimulation syndrome, which is an exaggerated response to the medication. Your estrogen levels skyrocket. HCG can cause the release of a substance in your body called VEGF, vascular endothelial growth factor. I know I'm hitting you with so many terms, but I promise you in the show notes, I will include all of these abbreviations and their names and what they mean. Okay, so VEGF is a substance that gets secreted in response to the HCG that causes new blood vessel formation and growth and vasculature around these follicles in the ovaries. And while that sounds like that would be a good thing, and it may be a good thing, which is why you can get more mature eggs, it also causes these capillaries to become very leaky. And so a lot of the blood volume will seep out of the vessels and then third space into the abdominal cavity, sometimes into the lungs. And as that fluid shifts out of the blood becomes more concentrated, so that in severe cases, it predisposes you to not only having tons of fluid in the abdomen and in the lungs, making it hard to breathe, but can predispose you to blood clots, including clots in the lungs or strokes, which both of these can be fatal. So that can be a very extreme complication if left unmanaged, untreated. So when we see that estrogen levels before trigger are very, very high, and I've had cases where I see it at 10,000, which is crazy, I cannot give HCG. Now, the reason why this is sometimes scary, and you will see that this is somewhat controversial between doctors, you may have two doctors saying totally different things. I've had partners say, I love Lupron, you only need Lupron, you never need HCG ever. And I hate making statements like that because not everything works for everyone the same. And there are patients who truly need the HCG. But the downside is the scariest part is when you give no HCG to someone who's really hyperstimulating. And it rarely happens, but it has happened to many of my partners. Luckily, it hasn't happened to me yet, but it's inevitable and probably going to happen one day, where you give a double Lubron trigger, you go in to do the retrieval, and there's so many follicles, such high estrogen, and you're not getting eggs at all. And in some cases, you get no eggs. And that person really needed the HCG. Few and far between. I haven't experienced it yet, but like I said, I know many people who have, and that's the downside. So we do love to give HCG trigger, most of us, but you also have to consider safety first. There are times where I have given it because I was really worried, given the hormone levels, that I would get no eggs. And then it backfired and the patient hyperstimulated and ended up in the hospital, and it's a whole mess. You don't want to ever have these complications. But you can't always predict who is going to cross into that zone of severe ovarian hyperstimulation syndrome versus who isn't. I started using caraway during my first embryo transfer cycle when I was deep into IVF prep, trying to control every variable I could. And my kitchen was one of those places. I wanted cleaner cookware, something without the sketchy nonstick coatings that I grew up cooking on. So I ended up purchasing the whole caraway set. And if you follow me on Instagram, you know I love to cook. Having a kitchen full of pots and pans that are beautiful brings me so much joy. And caraway ceramic coated pans are perfect for the person looking for nonstick cookware where the eggs slide right off with barely any oil or butter. Cleanup takes seconds, and they're the kind of cookware where you don't feel the need to hide them in your cabinets, since if you're like me, guilty of washing your cookware and leaving it on the stovetop because they're beautiful. I'm personally loving the stainless steel set right now, which I've been heavily using, while my husband is definitely the one who prefers the ceramic pots and pans. Caraway is in over 2.5 million homes right now, with over 155,000 five-star reviews from people who have made the switch. And third-party labs have independently tested and verified how they're made to ensure that they're free of PFAs. So right now you can save up to $230 on the 12-piece cookware set compared to buying everything individually. And there's even more savings across Caraway's full kitchenware collection. So visit carawayhome.com/Dr. Sasha for an additional 10% off your next order, or use code Dr. Sasha at checkout. That's carawayhome.com/Dr. Sasha, or using code Dr. Sasha to save. The word mitochondria gets thrown around a lot in wellness content lately, so let me just explain what they do. They're part of your cells that produce energy, and like most things in the body, that function naturally will slow down with age. And this is part of normal biology. One of the ways that your body maintains that function is through a process called mitophagy, where the damaged mitochondria get cleared out and replaced with healthier ones. And there's a compound that is shown to support that process called urolithin A. It's a postbiotic that your gut bacteria can make from foods like pomegranates, walnuts, but most people don't produce much of it that way. You need to eat a lot of both consistently to get any meaningful amount. And that's the gap that MitoPure is built around. It's Timeline's patented form of urolithin A that's studied over 18 years and across 12 human clinical trials. I've personally been taking it myself and honestly been loving it for my energy levels. And not to mention, the gummies are delicious. I'll keep the claims honest here, though. This is not a muscle building supplement. It won't replace sleep or training. And what the research does show, it supports cellular renewal and energy at the mitochondrial level. And in one trial, they found a 12% increase in hamstring strength, specifically after 4 months in sedentary middle aged adults. If you're curious about the more evidence based side of healthy aging, this is a reasonable place to start. So head to timeline.com/Sasha for 20% off Metapure gummies. Again, that's timeline.com/Sasha. I did it to myself. I shouldn't have given myself HCG, and I did anyways. And it's such a low dose, and I did hyperstim. But I guess I could be reckless with myself. I cannot be reckless with other patients. But this is why it's the preferred protocol for so many practices for patients across the board. And some will use it for every patient, regardless of their ovarian reserve. The other advantage of using an antagonist protocol is that you have a little bit of flexibility in the sense that if someone is having diminished ovarian reserve, and they have a tendency to recruit follicles before their period. And this can happen. If your egg reserve is really low, there is not enough of a hormone called inhibin. There's inhibin A and B, but we won't get into that. Inhibin is also produced by the cells in the follicles. And inhibin tells the brain during the luteal phase, we got lots of eggs here, no rush. Let's wait to find out if we're pregnant. And if we're not pregnant, now I'll let go, and then you can send out the FSH. If you have really low ovarian reserve, you have lower inhibin. It is not suppressing the brain from starting to release FSH before you even have your period. And so sometimes what it translates into is somebody with diminished ovarian reserve will come in on cycle day 1 and they already have a 12 millimeter lead follicle. And that's pretty big. You usually want it to be 8 or less. So you see that 12 millimeter and you're like, well, damn it, she already recruited. So now we're going to start the meds today, but it's going to be very desynchronous. It's going to be all over the place. We're probably going to get a lower egg yield. So one of the strategies to combat that, one of them is through priming, and another is through a luteal phase start. The luteal phase start means that in the mid-luteal phase, so about a week out from ovulation and before the period begins, you bring a patient in, you see their follicle count, it looks a little bit more synchronous. You start about a week before the period with the antagonist protocol, and it often works wonders at keeping that synchrony and improving the egg yield. I do this a lot, by the way. Now, that's another advantage of the antagonist protocol. So you have a lot more freedom to manipulate the timing of things to try to get a better and safer outcome. That is the beauty of an antagonist protocol and what makes it the most common. A variation of the antagonist protocol that I've been actually doing a lot lately is using Provera instead of the antagonist. So the antagonist is another injection. So usually with an antagonist protocol, you start with 2 injections, and then eventually a few days in, you add a 3rd injection to prevent that premature ovulation until you do the trigger. Okay? And with the alternative to that, because although the antagonist isn't too expensive ever since Trump RX, honestly, all the prices have come down quite a bit for medications at all pharmacies and clinics, which is good because everyone realized like they have to bring their prices down, otherwise they can't compete anymore. And what I like to do is add a progesterone pill instead. So the beauty of the progesterone pill, it's called Provera, is that it's one less injection to take. The pill starts on the first day of stimulation. So you don't have to worry about timing of monitoring to figure out when to start the antagonist. So I love this because sometimes starting an antagonist is not that tricky, but sometimes patients will tell you things like, my job doesn't allow for me to come in on this day. I can't come in. I'm going to be out of town for a couple of days. I'll come back later, before and after. And you risk missing the window of when to start the antagonists, which, by the way, trade name in the US is cetrotide and GnRH. So if you miss that window, you risk premature ovulation and losing everything. With Provera, it adds a lot of flexibility for patients where they start on stim day 1. And let's just say, okay, I told a patient to come back on Wednesday, and they said, I can't come back until Thursday or even Friday because of work-related things or personal things happening. I really try to encourage patients to really follow the schedule, but I also work with where they're at in life and what their schedule allows for. With the Provera, it's cheap, it's a pill, and you don't ever have to worry about the premature ovulation because as long as you have progesterone in your system from the beginning, the brain thinks that, okay, we got progesterone, I'm in the luteal phase, there's no reason to ovulate. So it's a very, very, very good way to prevent ovulation, and the success rates are equivalent. So it doesn't matter if you use ganirelix, cetrotide versus Provera, they're the same. And there's plenty of data to show that. So that's sort of that whole antagonist protocol in a nutshell and the pros and cons of it. Now, the main reason I want you to understand why this is so advantageous for preventing ovarian hyperstimulation syndrome as well is because you can just give a Lupron only trigger. If you give Lupron, which is part of another protocol from the beginning, Lupron, even though it's a GnRH agonist, which by definition an agonist should stimulate, meaning it should cause the release of natural storage from the brain of FSH and LH. What's interesting is if you take it every day, because naturally speaking, it should be pulsatile. If it's a constant through the medication, it causes desensitization of the receptor. So a medication like Lupron for the first few days will actually cause the release of FSH and LH. But after a few days, it does the opposite. And it kind of becomes like an antagonist, except unlike an antagonist, which the second you stop it, it's out of your system and you can now stimulate the pituitary. A GnRH agonist, once it causes desensitization of the receptor, it is not quick or easy to reverse that. It takes a little bit of time. And so if you are taking an antagonist protocol, you can give Lupron as a trigger. But if you're getting Lupron throughout the entire stimulation protocol, you can't give Lupron as a trigger anymore because it's now having the opposite effect. So you have to give HCG as the only trigger. And that, my friends, is known as a microdose Lupron protocol. That is the main setting in which we use Lupron the whole time. Historically, there's an old school protocol that nobody uses anymore called a long protocol, which is where you would basically shut down the ovaries for a little while with the Lupron until it really suppressed the ovaries, and now you started the gonadotropins. The biggest downside to that is it took forever, very, very long protocol, and it's definitely not superior to any protocol we use now. If anything, it's probably the opposite. Now, with the microdose Lupron protocol, I actually love this protocol. I don't know why a lot of doctors hate it, but for the right candidate, it can really work wonders. And this is primarily for two sets of patients. Those who have really diminished ovarian reserve. Okay, so if your AMH is on the lower end of 1 or below 1, you are certainly a candidate for this protocol. Or those who have a higher AMH or higher egg reserve who previously did not respond well at all to the antagonist protocol. And so this is where you try something new. With the microdose Lupron, the way it works is in the very beginning of the menstrual cycle, so cycle day 1 is when I really like to start it. The sooner you start in your menstrual cycle, the better. This is where I always tell people, let me know a few days before your anticipated period. Don't tell me after you started your bleed, because then we risk your body trying to recruit a dominant follicle and it becomes a dysynchronous cycle. I love starting on cycle day 1 for that reason, so that the follicle sizes are closer together and they can grow more in sync and you have a higher egg count, especially if you have low egg reserve. So if we're doing a microdose Lupron protocol, I like to start the Lupron on cycle day 1. And then 2 days after that, unfortunately, you're taking it twice a day, so morning and night. And then 2 days later is when you add on your gonadotropins. And so what it does is it causes this flare up of your pituitary releasing all of the internal storage of FSH so that it gives a huge boost to your ovaries to grow and recruit these follicles. And then once you add the gonadotropins, it's continuing to grow the follicles, but eventually at this point, usually 3-4 days in, the Lupron now has desensitized the receptors so that your brain will not ovulate these follicles. I have never, ever, ever in my career seen a case of premature ovulation with this protocol. And women who have low egg reserve are at a much higher risk for prematurely ovulating. That's why I love this. The risk of premature ovulation is so low, and the response tends to be pretty robust. And so this is where I've seen really great outcomes, especially in patients who had previous poor response. And now I'm the lucky second doctor who gets that data in order to optimize the protocol, change it, and get more eggs. So I will say that about medication protocols. If you're going to a second doctor and you get a much better response, always remember the second doctor had the data that the first doctor did not have. So that's a big deal. So that's microdose Lupron in a nutshell. You're taking Lupron small doses morning and night. It initially causes a good surge for the recruitment of those follicles. You add the gonadotropins, it continues to grow all these follicles, and then the only trigger you can give is the HCG. Every now and again, you will have someone with diminished ovarian reserve who will hyperstimulate from this protocol. It's rare, but it can happen. Sometimes AMH is low, follicle count is low, and then you just get this crazy response out of nowhere. Usually those are the patients, if they hyperstimulate, they're the only patients I've ever seen who are happy because they're like, I thought I was going to get no eggs or very few eggs, and I can't even believe how many eggs we got. This is insane. I'm not even going to complain. But it does feel like crap, so we always want to avoid that. So that's microdose Lupron. Main patient it's for is someone with diminished ovarian reserve. The biggest downside is 4 shots a day, but the plus side is that you get a very robust response. And this is really good for someone who previously did an antagonist protocol and did not respond well at all. Now, those are the 2 main popular ones. There is a third one that is not mainstream at all, but in my last practice, we did clinical trials on this, and it works exceptionally well, once again, in the setting of diminished ovarian reserve. And this is actually the protocol I did for myself, not having diminished ovarian reserve, and one that I use for older women who also don't have diminished ovarian reserve, and you tend to get a really great response. And this is called the long Clomid protocol. This is where you basically give 100 milligrams, so 2 pills of Clomid every single day throughout the entire stimulation. And what the Clomid does, Clomid blocks the estrogen receptors in the brain. So it tricks the brain into thinking that the estrogen levels are low. And so it basically preferentially causes a release of FSH. And so you take Clomid with Follistim only, no Menopur, because Menopur has a little bit of LH. You don't want to stimulate premature ovulation. When you take Clomid with Follistim alone, you are extremely unlikely to prematurely ovulate, and you get a pretty robust response. The trigger with this is usually HCG, and that is traditionally what the clinical trials studied. However, in many cases, I also added Lupron and did a co-trigger. I've never done Lupron only with this protocol, so that would be experimental. And theoretically, it should work, but I don't know how well it works in comparison to getting HCG. So this protocol is primarily for the patients who have lower egg reserve. The main advantage is cost savings. You significantly reduce the risk of premature ovulation, which is once again a very big deal with diminished ovarian reserve. And you're only taking 1 shot a day. And this is a big deal, especially if you are at a clinic that doesn't offer needle-free IVF. I do needle-free IVF on a lot of patients, so the number of injections never plays a role in my medication protocol because if they're using the catheter, they don't care because you're not doing the needles. So there are many clinics doing it now. Also, If you're at a clinic that doesn't necessarily offer it, fun fact, that is probably not being advertised enough. MDR Pharmacy, this is not, I'm not getting paid to say this by any stretch of the imagination. I wish I was, because I would say the same thing. But no, MDR Pharmacy offers needle-free IVF countrywide in the US. So you could be at any clinic that you want to. Of course, I was at HRC. They're not going to advertise that because they want all the patients coming to them. Um, but I really believe in access to care for everybody. And medicine should be open access. If we have something that can improve the experience of your IVF cycle, then you should absolutely have access to it. And it's really not any more expensive, maybe by a couple $100, so which is a drop in the bucket, unfortunately, if you're paying cash for IVF. So, yeah, needle-free IVF can be done through MDR Pharmacy. You just need to ask your doctor to order it, and they may be completely confused on what that is, and you can explain it to them. But they just have to put in the order, and MDR will provide everything you need, the kits, the videos, the instructions, all of it. So you don't even need a doctor who knows how to do this. That being said, I usually actually will hands-on teach my own patients how to do this, but, um, yeah, anyway, I digress. So back to medication protocols. So the long Clomid is great for diminished ovarian reserve. It's an alternate option. I used it a lot for a while, and then I sort of kind of went back to the microdose protocols because I still do feel like in general I have a better-ish response. The downside was the 4 injections a day, but now with needle-free IVF, anyone who does microdose Lupron, I encourage them to get the catheter so that they don't have to inject themselves 4 times a day, and that makes it a lot easier. So those are the 3 main sort of buckets. Now you have add-ons. I may not be an interior designer, but I really love a well-designed room. And unfortunately, I've learned over the years that a lot of this gets ruined when you have kids in the house. And we're talking my expensive dining chairs have been broken. A lot of the stains and paint on my furniture have been damaged, rugs permanently getting stained. And I previously bought these really fancy rugs before having kids. And after kids started to become paranoid, making the whole family stressed, panicking over spills on the rug and food even getting close to it. And this is why I love Tumble, because they're spill proof. So stuff will bead up instead of soaking into the rug, and they're fully machine washable, including the pad that's underneath it. And the pads tuck into the corners of the rug itself, so nothing bunches or slides. Well, when looking into this, of course, the material itself is what matters most to me. Every tumble rug is OECO-TEX certified, which means it's been tested for harmful substances and is safe for kids and pets to be on the floor with. And that's often a deal breaker for me when it comes to furniture. They also just look beautiful. It's so nice that I even got this beautiful blush one for my baby girl's nursery, and I was so excited to share that. Machine washable rugs made better. For a limited time only, our listeners get 10% off with free shipping at tumbleliving.com/Dr. Sasha. That's TUMBLE living.com/Dr. Sasha. And after you purchase, they will ask where you heard about them. So make sure that you support our show and tell them that we sent you. Actually, before we get into the add-ons, I do want to quickly mention something about mini IVF because I do get asked about this a lot. And mini IVF is appropriate for those who really do not respond well or have very few follicles. And I'll tell you why. If you have a lot of follicles, mini IVF is just not for you. You are now creating inefficiency and a higher likelihood of needing to do more than one cycle. I am unfortunately seeing doctors online who are saying things like, it's all about quality, not quantity. And the studies have repeatedly shown that medication dose doesn't affect the euploid or chromosomal status of the egg. And so you are actually creating more efficiency if you get more eggs. You're not compromising the quality of the eggs. But if you are minimally stimulating someone who has a good ovarian reserve, you are increasing the likelihood that they may need to do this multiple times, which, sounds like a really good incentive to make more money, in my opinion. So I rarely do mini IVF The main times I do it is if somebody has really, really low egg reserve. Now, what's happening is with mini IVF, the gist of it is you're giving very low dose gonadotropins with an oral medication such as letrozole or Clomid. So, like I said, with Clomid, it blocks the estrogen receptor in the brain, makes the brain think there's not a lot of estrogen, so the brain secretes FSH. Letrozole is an aromatase inhibitor, so it blocks the conversion of testosterone to estrogen because testosterone is the precursor to estrogen. And so, once again, if the body thinks, the brain perceives that the body has low estrogen, it will secrete more FSH naturally on its own. And letrozole and Clomid are relatively a lot more inexpensive. Letrozole is cheaper than Clomid, at least in my experience as a patient. I had to pay way more for the Clomid than the letrozole when it was cash. Um, but both are pretty equivalent. And then you combine that with very low dose of gonadotropins. In some patients, going above 150 units of gonadotropins is not going to be beneficial. It's just going to cost the patient more money. And so that is when I like to use mini IVF. If I know that you have 2 to 3 follicles, that's the most we're ever going to get, then we're doing mini IVF and we're going to save you some money to get the same outcome. That's when it's appropriate. But it's not really appropriate across the board. Now, for the IVF add-ons. I already mentioned 2 of them, Clomid and letrozole, which are pills. Letrozole is a common add-on for breast cancer patients. So anytime I have an oncofertility patient, someone who's recently diagnosed with breast cancer, they're awaiting their mastectomy, they're about to undergo chemo, and now we want to do fertility preservation, especially when it's an estrogen receptor positive breast cancer. It is totally safe to stimulate the ovaries. It does not upstage you. It does not increase the risk of recurrence. And doing IVF, definitely these medications do not cause breast cancer, ovarian cancer, any of that, or any cancer for that matter. And this has lots of data to back it up. But for the breast cancer patients or anything that is estrogen dependent disease like endometriosis, I love to add letrozole because letrozole, once again, is an aromatase inhibitor. So it blocks the conversion of testosterone to estrogen. So what happens during these IVF cycles? The estrogen levels remain pretty low, almost physiologic. You don't see these crazy high levels of estrogen that you would see in a normal IVF cycle. So my patients who have endometriosis that is symptomatic, I usually tend to add letrozole for the entire stimulation. And then also for breast cancer patients. And then also for those who have really diminished ovarian reserve and other protocols have not worked, I will often add on letrozole. Another scenario, and I actually learned this from Dr. Amy, the egg whisperer. Um, we talked about this once. We had a mutual patient that we were managing, and she came up with the idea because the patient had very low maturation with Lupron-only trigger, and I really wanted to give HCG, but she had really high ovarian reserve, and so I gave letrozole with the antagonist protocol in order to be able to give an HCG trigger. So sometimes you can do that if you're really worried about ovarian hyperstimulation syndrome. You also have historical data from prior cycles showing that maturation is very low without the HCG. And so that is sort of an attempt to do that. This is not evidence-based. That's a little more experimental, but anecdotally, it seems to work. You usually will use letrozole for the clinical scenarios I just mentioned, which is diminished ovarian reserve. Um, Usually in those cases, you actually only use it for about 5 days of the stimulation. And then for breast cancer, endometriosis, you use it throughout the whole stimulation to keep estrogen levels low. Or if somebody has some sort of estrogen-dependent disease, like I've had some patients tell me that when their estrogen rises, that's when they have seizures. And so I'm like, all right, let's just keep it down with the letrozole. Clomid, same concept. If you do the long Clomid protocol, you're taking Clomid the whole time. But if you're doing Clomid as an add-on to improve the response, then you usually give it for 5 days. Some studies show it works really well, others showing not so much. But it's a fairly overall harmless, inexpensive add-on. Another add-on is Omnitrope, and this gets a lot of popularity online and from patients in the clinic asking me about Omnitrope. And what's really tricky about omnitrope is that if you look at large bodies of data, the pattern generally is that it might be helpful, but it hasn't really been proven to be helpful. And I find it funny when other specialists disagree with me on this because it's just the data. But what I want to say about data is that when you have smaller bodies of evidence and you look at the research, you are going to have studies that contradict each other. And that's what's so tricky about research. If you rely on one particular study to make decisions on how to manage populations of patients, that is problematic because one study will contradict another study. One study will show that omnitrope does nothing. Another study will show that it improved the live birth rate, which is a really big deal because that is the end goal here. Now, let's say I look at patient A, who I gave omnitrope to. I got an amazing response. And from her perspective, she thinks omnitrope is a miracle drug. And then patient B, I gave her omnitrope and we had the worst response that she's ever had. And she thinks omnitrope is a terrible drug. And this is why in medicine, you cannot rely on single studies and you cannot rely on anecdotes. You have to look at the whole large study or the large body of data that's available. And so this is where I like something like a Cochrane database where they look at all of the studies. They compile all of the data from all the studies. They look for bias, they look for inconsistencies, and then from there they can make a general recommendation of, is this helpful or is this harmful or is it neutral? And omnitrope is one of those things where it's might be helpful, but the available evidence is fairly low quality. Larger meta-analyses shows that it's kind of neutral. So this is where it becomes nuanced, where if I see that somebody has previously received omnitrope, they responded great on it, I ain't changing it. Or if somebody wants to try it, and especially if they have coverage and it's not going to cause financial stress, absolutely, why not? Why not try it? So that's where it becomes a little bit tricky with the omnitrope. I've had cases where patients are like, I can't afford this, and they get nervous that that's what's going to make or break their cycle. And I reassure them that no, and I definitely do not want them to have any financial stress surrounding it. But for others, it is no big deal. And if you're listening to this and you're really wanting to try omnitrope, I have had patients tell me, and I can't tell you how they did it. So I would definitely look on Reddit for this. Look at me, a doctor telling you to go look on Reddit. But apparently, Costco has some sort of program, if you have a Costco membership, to get omnitrope free, at least for one cycle. So there goes that cost variable. But it's not too expensive, but obviously it adds up. Those are the main add-ons that you will have in addition to your IVF meds. There's also priming, and some will call it add-ons, but it's really more so priming. Priming is what you're doing in the menstrual cycle leading up to this cycle for ovarian stimulation. And so what priming is, the purpose of it and the goal of priming is to either control the size of the follicles to keep them more in sync and you get a better response that grows together in higher number of eggs, or it is to actually improve the response to the medications. So let me explain. So you have one type of priming that some clinics will do, and that's part of their protocol, is birth control pills. I think birth control pills are great for priming, especially if you have really high egg reserve. If you have PMOS or very high ovarian reserve, suppressing the ovaries a little bit and leading up to your stimulation just for a couple weeks can be really helpful. Especially if you're somebody who tends to recruit early for whatever reason, you have a larger follicle or your follicle sizes are all over the place. It just kind of quiets them down so they're similar in size. And now when you start your gonadotropins, they grow more in sync and you have a higher egg yield at the time of the retrieval. And So that's one strategy. I pretty much only use it in that setting. There are clinics who batch, and I know that batching gets a bad rep, but it's really not bad. With batching, some clinics only have capabilities of doing retrievals a certain number of times per month. The main reason is if it's a smaller, more boutique practice, sometimes they just don't have the staffing availability, whether it's the embryology lab and they have embryologists who work per diem, or it could be that anesthesia staff, like my first practice in Michigan, we had to batch because we only had an anesthesiologist or a CRNA certain weeks of the month where she was available. And so it led to sort of scheduling trickiness where I had to batch. But you know what? My pregnancy rates were amazing. It didn't impact that whatsoever. And it really didn't change when I stopped batching. But what it does translate into a little bit is having to go in and do retrievals like every single day, as opposed to having certain numbers of days and feeling like you can get a little bit of a break. Um, and this is just me being transparent, but I don't batch anymore. But batching is not a bad thing. I know people say like don't go to a clinic that batches and that isn't open 7 days a week, but I know a lot of practices that do, and their pregnancy rates are fantastic. And so obviously, if you have a special case, you can always talk to that practice and say, hey, I really don't want to be on birth control pills leading up to this. And hopefully they can respect that. But if they can't accommodate it, that's when it's really time to look at a different clinic that is really 7 days a week type of thing. Um, the other kind of priming is for totally different reasons. So if you have diminished ovarian reserve, a common form of priming is an estrase pill for starting in the mid-luteal phase. So 1 week after ovulation, this is where your doctor will usually tell you, I want you to track your ovulation. I want you to tell me when you have an LH surge. A week later, we're going to start estrogen pills. I tend to have my patients place it vaginally, and then they come back 1 week later exactly on their anticipated period. It might be delayed a little bit, but if everything looks good, then they're good to start. And it prevented that premature recruitment of a dominant follicle that will cause asynchrony in the cycle. And then it also upregulates the FSH receptor. And so you usually will get a better response if you estrase prime, especially if you have the lower end of average or below average egg reserve. There is a subset of women, however, where it will backfire. And I have had this happen with patients where I give them estrase and then all of a sudden the follicles are so small. So what I started doing in terms of priming, and I don't even know if anybody else does this, but I actually bring all my patients in for baseline 1 week before their period to see how things look. Do the follicles look big? Are they smaller? Are they really, really small and we really need to wait? Based on what I see on ultrasound in the mid-luteal phase, that's when I decide, are we starting luteal? Are we priming and then starting in a week? Or are we just doing a straight start at the beginning of the period? So that's how I sort of do things now personally. Um, Other ways to prime that I rarely do now, but this is really for the refractory cases where you don't know what else to do because you've tried all these different protocols, you're not getting a great response, and you're trying to get creative here. Um, this is where you can add testosterone with the estrogen for priming. Some people will also prime with growth hormone or omnitrope. And so there's a lot of different ways to get creative there with the priming. And the jury's still out on how much it really helps. There are small studies showing that priming with things like testosterone can be very helpful. DHEA, on the other hand, has not been shown ever to be helpful. So this is where I'm not a fan of DHEA supplementation. If you're going to supplement something and you want to prime, just use testosterone, not DHEA. There's decent research to back up the testosterone and it's good clinical outcomes with it. So I would definitely personally use testosterone. There's different formulations of it. A common one that we use in fertility clinics is androgel, which is like a topical gel that you put on your arm, and in combination with estrogen. and then you would go ahead and start your stim a week later. You'll probably bleed through it. Some people will prime for longer than a week, sometimes 2 weeks, 3 weeks, a month. I don't love priming for too long personally because I do think that eventually it backfires where you suppress the ovaries too much. Um, Once again, the exception is if you have really high egg reserve. So what I will say about all of these protocols, if somebody is a good responder, it truly doesn't matter what medication protocol you choose. They're going to respond well. They're usually going to respond great. You can switch up the protocol. It's probably not going to make much of a difference because at the end of the day, the main thing that matters is the gonadotropins to stimulate the follicles. But there are the subset of patients, the small percentage of patients, where the standard protocols just don't create the response you want, and now you have to play around with it. And so you need to take that data from previous cycles, use it to change how you're going to do things moving forward. So this is where I find second opinions to be very advantageous. When someone comes to me with all their records and I see their prior IVF cycle protocols, I now get to see what didn't work and then choose to do something that works better. Or if someone had a great response, but they're leaving the practice because maybe they had a bad experience or maybe they moved and now it's a location issue, and I see that they had a great response, I also get to use that data to give them the same protocol because why change it if it worked great? So that's all the IVF protocols in a nutshell. I'm really curious to see what was surprising from this, what is confusing. I'm always happy to clarify this. I think understanding medication protocols is really important because even when I explain it to patients, I think there's still a big lack of understanding with how important it is. It's hard to say truly how important the medication protocols are. For the majority, like I said, it probably doesn't matter. But for a subset of patients, it is going to matter a lot, especially if you're closer to 40 or past 40. And if you've had failed IVF cycles in the past with no embryo development or really poor response, this is where changing up the medication protocol can be beneficial. But, sorry, I just have to itch my nose here. Ugh. But one caveat to that I do want to share based on a really well done study, actually. What we know in the literature is that repeating the same protocol, even if you've had a not so great outcome, actually is usually better for most people, believe it or not. We don't know why that is. Um, but we see that overall, large bodies of data show repeating the same protocol is more advantageous. There's probably something about it priming the ovaries. And this is why, in general, when you do 2 IVF cycles back to back, the second one tends to be better because the ovaries are primed, they're juicy, they're ready to roll. And so, and obviously these are generalizations. So if you're like, that wasn't me, of course, that's not going to be everybody. Some people may have a worse response the second time. Some people change the protocol and the response is so much better. And I've even had, a patient where we did an antagonist protocol because she has normal AMH, great AMH, very poor response. I thought maybe it's a fluke. We did an antagonist protocol again. Even worse response. I couldn't believe it. Almost no mature eggs. And then I switched protocols. I did a completely different protocol and night and day difference. I mean, night and day. We went from having 3 mature eggs out of 14 retrieved to 18 mature eggs the next cycle. That's such a stark difference. And this is where you see some of these patients, there's probably something genetically going on that's causing this difference in response to the medications that we just don't have that information of yet. I know we're headed that way in our field, but we're not there yet. So it's not always inappropriate to repeat the same protocol, but I also understand from the patient perspective, if something really didn't work and they want to try a new protocol, I think that's fair, but just also know that the research shows doing the same protocol twice actually may be in your favor. If you heard my episode on what I did for my IVF cycles, one at 32, one at 37, I did two totally different protocols, but I landed somewhere around the same yield of embryos. So, except in one cycle, they're untested, the other one, they are tested. So, that's kind of like unfair information to compare, but the number of blastocysts were pretty equivalent despite being 5 years apart. So, it just kind of goes to show you the response to medications is what the body usually is going to want to do, what it's available to do. And always remember, we cannot control the follicle count. Follicle counts can fluctuate quite a bit. We can't predict how it's going to look like in a few months. Is it going to look better? Is it going to look worse? We don't know. And that is the greatest limitation of our field. We do the best we can with the data that we have available to us. And hindsight is always 2020. But you control the variables you can through lifestyle and through optimizing your natural fertility. But IVF protocols is another place where we can tweak and fine tune as best as we can. So please, 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 if you have any questions, comment, let me know, DM me, wherever. But definitely when you do leave comments on the episode under the show notes, that definitely helps with the engagement of the show, helps make it more successful. And so it's my one ask as I sit here late at night just trying to give you free information. So I hope this was helpful. I know this was a lot, and I know this can be a little bit confusing. And there's probably even more variations that other people do in terms of medication protocols, but these are pretty much like the main ones that are used at least throughout the US. Okay, until next time. Thanks for listening to this episode of Trying with Dr. Sasha Hakman. Don't forget to subscribe, and if there is anything in particular you want to hear about, leave it in the comments section. Episodes drop every Wednesday.